Welcome, MRCOG candidates, to this explainer. As your clinical mentor, I am absolutely thrilled to be guiding you through the essential facts of Green-top Guideline 41. We're going to break down the initial management of chronic pelvic pain just to make absolutely sure you're fully prepared and super confident for your exams. Let's get started.
Okay, let's dive right into this authoritative framework. Chronic pelvic pain is incredibly common. In primary care, it actually presents just as frequently as migraines or lower back pain. Yet it's notoriously complex to manage and carries a massive economic and social burden. Aiming for an accurate diagnosis and effective management from the very first presentation is absolutely crucial. It prevents those endless cycles of referrals and disruptive symptoms for the patient. And this guideline, it gives us exactly that. A fantastic evidence-based roadmap designed specifically to streamline the whole process.
To perfectly mirror the exact clinical pathway you'll use in your OSCEs and written papers, we're going to structure this explainer across 5 critical steps: defining the condition, identifying etiological factors, the initial clinical assessment, evidence-based investigations, and finally, initial therapeutic options.
All right, starting off with Section 1, defining chronic pelvic pain. This is the foundational knowledge you absolutely must have locked down for the exam.
You need to memorize this criteria closely. We are talking about intermittent or constant lower abdominal or pelvic pain, lasting for at least 6 months. And definitely note the specific exclusions here. The pain cannot occur exclusively with menstruation, intercourse, or be associated with pregnancy. That 6-month time frame and those specific exclusions are incredibly high-yield facts for your written papers, so keep them top of mind.
Now this right here brilliantly illustrates the core paradigm shift you need to demonstrate to your examiners. Chronic pelvic pain is a symptom. It's not a diagnosis in itself. It requires a curious, open-minded investigation rather than just jumping to immediate assumptions. We are trying to identify contributory factors here rather than hastily assigning all the blame to a single pathology.
Moving right along to Section 2, let's look at identifying those etiological factors and how we untangle this multifactorial symptom.
You've really got to broaden your gynecological differential diagnosis for this one. The guideline stresses that there is almost always more than one component to chronic pelvic pain. For instance, did you know that up to 50% of women presenting to gynecology clinics for pain actually have symptoms suggestive of IBS? It's huge! Interstitial cystitis is found in roughly 38 to 84% of these women in secondary care. You also have to consider musculoskeletal pain, like pelvic floor spasms. Don't forget nerve entrapment either. That can happen after something as routine as a simple fan and steel incision. And critically, psychological and social issues, including a history of trauma, frequently coexist and absolutely must be factored into your holistic picture.
Now, a really crucial clinical distinction to look out for is cyclical pain. While conditions like IBS can vary a little bit with the menstrual cycle, if you're taking a history and the pain is strikingly cyclical, well, that's your primary clue pointing toward a hormonally driven condition. It strongly suggests endometriosis or adenomyosis, and it should immediately guide your therapeutic thinking, as we'll see in just a bit.
Let's move on to Section 3, the initial clinical assessment. This is exactly where your clinical communication skills will be heavily tested, especially in an OSCE setting.
The guideline makes a beautiful point here, explicitly stating that adequate time should be allowed for this initial assessment. Get this, a favorable patient rating at the initial consultation has actually been associated with complete recovery at follow-up. Allowing time to listen, truly validating the woman's experience, eliciting her own ideas about the pain, and building a real partnership can significantly improve clinical outcomes and concordance with treatment. It's a game changer.
But while you're building that lovely partnership, your clinical brain must simultaneously scan for the high-yield red flag symptoms outlined in Appendix 2. We're talking bleeding for rectum, new bowel symptoms in women over 50, new pain after menopause, a palpable pelvic mass, or any suicidal ideation. Spotting any of these mandates prompt, specialist investigation, and referral. Seriously, these are absolutely critical for your exams.
Once you've completed your comprehensive and empathetic assessment, it's time for Section 4. Evidence-based investigations.
Always keep the RCOG grading system in mind here. In our practice, we are relentlessly looking for those highest quality grade A and B interventions to anchor our clinical decision-making.
So what does the evidence actually support? Well, your first-line investigations should be targeted and generally non-invasive. You should offer STI screening, particularly for chlamydia and gonorrhea, to all sexually active women. Transvaginal scanning is highly appropriate to identify adnexal masses, like endometriomas. For diagnosing adenomyosis, both TVS and MRI are incredibly useful and have comparable sensitivities. Plus, if a woman over 50 presents with new IBS-like symptoms, think bloating, early satiety, or urinary urgency, you absolutely must measure her serum CA-125. Now let's transition for a second and contrast these non-invasive imaging techniques against surgical intervention. The guideline has significantly updated its stance here, and you really need to be aware of this shift.
This is the crucial point for your modern practice and exactly what examiners want to hear. You must step away from immediately offering a diagnostic laparoscopy as a first reflex. It is simply no longer considered the automatic gold standard for chronic pelvic pain. Instead, it's much better viewed as a second-line investigation to be used only if other therapeutic interventions fail.
And the evidence shows us exactly why we've made this shift. Up to half, yes, half, of all diagnostic laparoscopies for the symptom find absolutely no pathology. That just leaves patients disappointed and potentially disengaged from care. Furthermore, laparoscopy carries very real measurable risks. There's an estimated risk of death of 1 in 10,000 and a 2.4 in 1,000 risk of severe injury to the bowel, bladder, or blood vessels. You have got to thoroughly counsel your patient about these risks before ever booking a theater slot.
Finally, let's wrap up our clinical pathway with Section 5, Initial Therapeutic Options.
Let's look at how all this evidence builds a modern management strategy. This is a massive Grade A recommendation for your exams. When a woman presents with cyclical pain and no abnormality is palpable on examination, you should always initiate a 3 to 6 month trial of hormonal treatment. That could be the combined oral contraceptive pill, progestogens, or GnRH analogs. Offer this trial first, assess her response, and only then consider a diagnostic laparoscopy if the empirical treatment actually fails. Simultaneously, you need to actively manage the non-gynecological components of her pain. If she has IBS symptoms, offer a trial of antispasmodics like mebaverine and suggest dietary changes. For general pain relief, prioritize NSAIDs with or without paracetamol, and make sure you absolutely avoid prescribing regular opioids. If the pain feels neuropathic, adjuvants like amitriptyline or gabapentin are excellent choices. Remember, treat the whole patient, not just the pelvis.
Oh, and note this very specific exam fact before we finish up today. Laparoscopic uterosacral nerve ablation, also known as LUNA, has been definitively proven to be ineffective in the management of chronic pelvic pain. Just don't recommend it.
As we conclude this explainer, I want to leave you with a challenge. Think about how you will actively shift away from that surgical tunnel vision. Your patients and your MRCOG examiners expect a holistic, evidence-based partnership. Listen to their story, screen for red flags, utilize non-invasive imaging, and always try empirical medical therapies before turning to the scalpel. Best of luck in your exams, and thank you so much for learning with me today.